The Lord placed his servant Esther in a position of leadership as an instrument of protection. When Esther was crowned queen of the Persian Empire, she did not know the kind of destiny the Lord purposed for her to fulfill. Yet, she committed her life to modeling faithfulness, devotion, and surrender. Whatever God told her to do, she would obey. Esther's posture of dependence on God was tested when her cousin Mordecai informed her of Haman's hatred towards Jews. Haman's cruelty was nearing its zenith, and an impending genocide was on the horizon. Mordecai urged Esther to appeal to King Xerxes on behalf of the threatened Jews in his kingdom. This was a daunting challenge, for to enter the king's presence without being summoned was a risk that could end with Esther losing her life. Esther could have said, "I grew up as a slave, and now I am a queen. Why risk it all?" But she did not give in to fear or opt for self-preservation. Rather, she was impressed with a sense of the urgency of the moment. She heard God's voice of providence saying, "This is the way, walk in it." She had been called to the kingdom for such a time as this. Filled with faith in God's wisdom and carried by courage in his protection, Esther approached the throne of the king. By God's grace, Xerxes received her with favor and heard her appeal. Because of Esther's sacrificial service, an entire nation was spared. Esther's courage has inspired generations of young women and young men. The Lord ordained this young woman as an instrument of national preservation. The light of her legacy still shines and is needed now with ever-increasing urgency. My friend, God positions us where we are needed, when we are needed. We have been called to leadership for more reasons than we know. Like Esther, let us watch the times with a discerning eye and be willing to stand for the oppressed. Today, ask God for a servant's heart and trust his direction as best.
To Jesus I surrender all. To him I freely give. I will ever love and trust him in his presence daily. I surrender all. I surrender all to thee, my blessed Savior. I surrender all to Jesus I surrender. Humbly at his feet I bow. Worldly pleasures all forsake and take me, Jesus, take me now. I surrender all. I surrender all to thee, my blessed Savior. I surrender all. Jesus, I surrender. Make me Savior, wholly thine. Let me feel the Holy Spirit. Truly know that Thou art mine. I surrender all. I surrender all to Thee, my blessed Savior. I surrender all to Jesus. I surrender. Now I feel the sacred flame. All the joy of full salvation. Glory to His name. I surrender all. I surrender all to Thee, my blessed Savior. I surrender I surrender all.
Strong Youth,
Strong Church.
welcome everyone to our Adventist Youth Program this afternoon. We are live here from our Mountain View College Media Center. And again, we welcome you because murag dugay-dugay kita wala kabalik, Ma'am Star.
Good parons.
Yes, and last Sabbath was sponsored by Mountain View College Academy, and I would like to personally take this opportunity to thank Mountain View College Academy for the very wonderful program. I think that was headed by Ma'am Shine Abdurrahman. Thank you so much, Ma'am Shine, and your students. This Sabbath, as we come back to ang regular Adventist Youth Program, we'll be talking about an issue or a topic.
Controversial topic.
A controversial topic. Yes, because this is very important, and not just important, I believe that this is relevant. My wife told me nga, uy, na late na taog discuss about this topic. But I believe dili pa siya late, no? So the more platforms that we'll share about this topic, I think the more informed that we could become. And so to talk about this topic this afternoon, we have invited a very important guest to join us. And later, he will be introduced to us by Mom Star. For now, we will be opening our program with our Adventist Youth Shine On theme song, and then I'll be opening with a prayer.
See the light way, darkness it breaks into the hope of dawn. And one by one, the shadows they run, vanquished by light and sun. Yet every day we need to let His light shine through. Study and love and live and serve together, me and you. Shine through the light, shine through the night, shine in the darkness, shine on through His mind. Let the light shine through. Adventist youth will say to you, shine through the light, shine through the night, shine in the darkness, shine on through His mind. Let the light shine through. Adventist youth will say to you, shine on.
Shine on.
Adventist youth shine on.
Shine on.
Adventist youth shine on. Shine through the light, shine through the night, shine in the darkness, shine on through His light. Let the light shine through. Adventist youth will say to you, shine through the light, shine through the night, shine in the darkness, shine on through His light. Let the light shine through. Adventist youth will say to you, shine on.
Shine on.
Adventist youth shine on. Shine on.
Shine on.
Adventist youth shine on. Shine on.
Shine on.
Adventist youth shine on.
Bow your heads as I pray. Our Father in heaven, we praise you for this Sabbath. We praise you for your goodness to each one of us. We praise you, Lord, because you are our great God. You are good, and you always will. Dear Father, this afternoon as we open this program, as we start this program, dear Father, to learn more about certain issues that impact us and that we may also that we also need to take part of. I pray that you will bless us, that you will open our hearts, open our minds, especially with heavenly wisdom, knowledge, and understanding, so that, dear Lord, after our program this afternoon, we may be able to reflect and be able to respond as well appropriately and accordingly to this, especially in our response to this pandemic. Dear Father, we each have a part to take. And so as we listen to the lecture this afternoon, may it be that you will be with us. Lord, may your Holy Spirit fill our hearts this afternoon. Thank you so much, Lord, for the blessing that you will be bestowing upon us, especially with our equipment as we stream this program. I pray that you will continue to bless us and to work in each of us and through each of us. Thank you, Father, for hearing and answering our prayers. May you forgive us from all our sins. We pray this through Christ's name. Amen.
Amen.
Once again, thank you so much for streaming with us. Medyo dagan-dagan itong viewers this afternoon. And I believe it is because a lot of us would want to know more about the topic that we will be talking about this afternoon. And the topic is, Mom Star?
Busting the myths about COVID-19 vaccines. So, mga misconceptions din no about the COVID-19 vaccines.
Yes, kay parang daghan gyud kaayo. And you know, in the recent research webinar that we have had, I think this was also mentioned. We have what we call this vaccination hesitancy. No, because a lot of us No? I do not say a lot of you because I believe nga ako po mismo, I am hesitant na to get the vaccine for COVID-19. Although in the past, daghan magud kay og sources of information. And especially when we look at social media, daghan pod kayo. Pero how do we, this would kayo, like, because a lot of times we rely on sources nga dili pod reliable, and that has probably created a lot of doubts among us. And if you would see in other countries, murag daghan naman kayo og naka-undergo sa vaccination, but in the Philippines, medyo it's medyo gamay pa gyud. In fact, when we were asking sa atong LGU in Valencia, when they were asking like how priority man atong senior citizens, when we were asking kung pila na sa atong senior citizens ang na-vaksinan, murag wala pa nakatunga sa sa number of senior citizens that we have in the city. So you see, there is hesitancy kung like with regards to the vaccine. So this afternoon we will be talking about this. So the part of our program this afternoon, we will be having a short lecture to start with, and then there will be a short intermission number, and then we will be coming back after the intermission number for a question and answer portion. And so I hope that you would be able to comment your questions in our comment section so that we could address them later on. Okay, so without further ado, let us now introduce our speaker. Nga gipukaw nato sayo pa kayo. I think it's also 3:30 in the morning sa ilaha. Ma'am Star, please introduce our speaker.
Okay, all right. Happy Sabbath, brothers and sisters. It is my distinct honor to introduce our guest and resource speaker in this very timely, controversial, and crucial topic on COVID-19 vaccines. Now, so much can be said about the speaker. It would take up time, but time can better be used for his valuable presentations. Okay, I wish to be as concise as possible without compromising the salient credentials of our highly competent resource person. Dr. Gerald Lalaguna Pilayo is an epitome of excellence. As an alumnus of Mountain View College in his Bachelor of Science in Nursing degree, the whole MVC community has been very proud of him when he passed as the first placer out of 67,095 examinees in the Philippine Nursing Licensure Examination in December 2011. And again, passed as first placer out of 1,601 examinees in the Philippine Physician Licensure Examination in March 2018. In March 2020, he passed the Step 3 United States Medical Licensure Examination. From his elementary years until his studies in medicine and postgraduate medical senior internship at the University of the East Ramon Magsaysay Memorial Medical Center Incorporated, Dr. Pilayo has been consistently awarded in academic and leadership excellence. He was always number one in his classes, as class valedictorian in elementary and in high school, as summa cum laude in college, as first in rank in his College of Medicine, and the best in his internship. In all of his years in school, he has also been a consistent student leader, being president, officer, or member in the different leading student organizations. Dr. Pilayo has been a lecturer and reviewer of many review centers, both in the nurse licensure exam and the physician licensure exam. He has also co-authored books. He has been a recipient of so many awards and recognitions. Just the two most recent are Gold Humanism Award nominee 2021 by the Gold Humanism Award Society of the Arnold P. Gold Foundation, and Young Alumnus Award by UERM College of Medicine Alumni Association. For his scholarly or research publications, he has co-authored at least 27 peer-reviewed international publications, most of which are related to researches and studies on COVID-19. He is also a journal peer reviewer of international publications in the United States of America. He has also been involved in research, poster, or presentations in the USA. The research fields he is interested in are cardiorenal syndrome, hepatorenal syndrome, cardiovascular diseases, diabetes, hypertension, and autoimmune diseases. Dr. Pelayo has many affiliations, but let me cite only two: the Philippine Medical Association and the American College of Physicians. Our speaker is not only all about studies. He is also fond of playing the piano, playing badminton and volleyball, swimming, reading, and public speaking. He is happily and blissfully married to Dr. Ardis Arila Pelayo. They are blessed with one cute baby boy in the name of Zeb. At present, both of them are at the Einstein Medical Center, Jefferson University, Philadelphia, Department of Internal Medicine, Pennsylvania, USA, where Dr. Gerald is working as an internal medicine resident physician. What I have told you, brothers and sisters, about the speaker is only the tip of the iceberg. But one sure thing that he consistently testifies is the close relationship he has with God. Behind all his successes and victories is the amidst these challenges is the consistent grace of God in his life. Brothers and sisters, let us all be blessed as we watch carefully, listen attentively, and pray intently as Dr. Gerald G. Boy Pelayo busts the myths about the COVID-19 vaccines.
Okay, Doc Gerald?
Good afternoon, everyone. Happy Sabbath.
Happy Sabbath.
I'm very glad to be with you this wonderful morning. My apologies for waking up a little bit late, but I'm very grateful to be here with all of you. And I'm going to start. I'm just checking if I'm audible enough.
Yes,
Good.
we can hear you.
Sounds good. So I highly respect our host today. Ronel is a very good friend of mine, and I could not say no to his request to me. That was 2 weeks ago, and even if it's early morning here, I really dedicate this time and energy to really do this, to educate our people, especially my beloved Mountain View College and all of the people surrounding it, within it. So I would like to share this time with you, beginning with this wonderful statement that I'm not here to actually decide for you. I'm here to educate, and the decision lies in your hand. I highly respect everyone's decision. I really want, especially in my practice, my patients to be well informed about the risks and the benefits, and I will let them decide. That's autonomy. That's the principle in medicine. We let our patients decide. So this afternoon, I will let everyone decide after you listen to this lecture, I would say, and then we'll share some of our insights in the Q&A. It's very fitting to actually start off this discussion with the question of whether coronaviruses are real, because I think, this myths about vaccine boils down to believing if this pandemic is really real. If you don't believe that it's real, it's easy to say, I don't need vaccine anyway. That's just a made up disease. Anyway, that's just a pandemic. I don't know if you heard about it. There are a lot of unvalidated sources and links that I see over the social media about, it's this virus is just a gain of function. It's just a leak from the laboratory. So I just want to, run through with you the facts about coronaviruses. So these viruses are actually a group of viruses that can cause a spectrum of diseases, from the most mild, maybe mildest, to the most severe respiratory and gastrointestinal syndrome. So when I say I will mix up my words with English and Cebuano so everyone understands. Respiratory, that pertains to imong lungs, from your nose down to your lungs, and gastrointestinal, from your mouth down to your anus, so gut. This is a large group of viruses. As you can see from the root word corona, diha nagikan ng crown. As you can see, there are spike proteins that actually resemble the shape of a corona or a crown. And this is an RNA virus that has been known. I think this is the 7th coronavirus that can infect human beings. So this is not the first. So if you say this is just made up in 2021 or in 2020, that's not true. In fact, in 2003, we heard about SARS-CoV-1 in China that started, and then we had a pandemic during that time. In 2012, MERS-CoV, I hope you still remember, that has started in Saudi Arabia. And we heard about intermediate hosts for these diseases. Like for MERS-CoV, maybe camels, they had an intermediate host. I mean, from the animal to human being, asa unsa ang tunga sa ilaha, before the transmission. That is what I'm talking about when I say intermediate host. And 2019, the first case was actually detected last December. That started in China as well. Now we have a SARS-CoV-2. Okay, so these coronaviruses are common viruses that can cause common colds. If you're not aware of, as you can see here, this is the Coronaviridae family, and there are different coronaviruses around. You have alpha, beta, delta, and gamma. And here we're looking at this specific beta coronavirus. It's the SARS-CoV-2. And that's the focus of our study this afternoon. Okay, so to review the structure, as what I have said, these are spike proteins. These are very important to know. I don't have to explain, specific details about it, but it's important to know that spike proteins are the reasons why we have the diseases, because spike proteins can attach to this receptor. In our body, it's always about lock and key. There's a receptor from a human body, and then there's this something from an invader or for a foreigner. Once they attach to its appropriate receptor, just like a lock and key, then that virus can go inside that certain cell, infect the cell, burst the cell, kill the cell, and spread. So, in fact, this is the focus of vaccine production. We want to mimic the spike proteins. We want to end up with producing spike proteins. We can use the spike proteins itself, we can use the virus itself, or the genetic material to induce the production of that spike proteins. And remember, once the spike proteins attaches to your ACE2, very fancy, but that's just an angiotensin converting enzyme 2 receptor. This is what the scientists noticed. That once the spike proteins attach to that receptor, then diseases come out and the symptoms come out. In fact, as you can see here, these ACE2 receptors are all over the body. That's why when you heard about symptoms for SARS-CoV-2, then you can have from the most maybe generalized symptoms to the most specific. Sometimes people can present with just coughing and colds. Sometimes they lose their ability to smell. That's what you call anosmia. Sometimes they can lose their ability to taste. That's what you call ageusia. Sometimes they can present with chest pain. Sometimes, very rarely, they can present with the visual symptoms. They can also affect the liver, the bladder, You can irritate, you can present with UTI as part of a syndrome or a constellation of symptoms that can also affect your pancreas, and they can present with very high blood sugars. And you don't know they have coronavirus, it's SARS-CoV-2. They can infect the brain, maybe inflammation of the brain, the covering of the brain we call meningitis, or the brain parenchyma itself we call encephalitis. And you can affect the placenta. So these are generalized. Oh, this is a systemic disease that can affect almost all. But initially, we were thinking only the lungs. That's why you see this X-ray, horrible X-ray with opacification all around until they become obliterated and the patient cannot breathe anymore and they get intubated. So most of the ACE2 receptors are in the lungs, but remember that this disease is systemic. It can affect any part of the body. Now the question becomes, is it real? You heard about gain of function research. I have received a lot of questions over the social media about this. Is this a leak from the laboratory? Is it really a real mutation? Or is this just a made up SARS-CoV, maybe a mutated version of the original coronaviruses? And then they just leaked it in the lab intentionally to spread disease intentionally and then make up some vaccine intentionally for business purposes. So that's always the question. So that's why it's nice to go back to that same question. So we have to, make things clearer if this is really real or not. Now, what I'm be presenting you this afternoon is just research-based. I'm not presenting anything from me. And we always have to use validated sources. When I say validated or reliable sources, I'm talking about New England Journal of Medicine, Journal of American Association, JAMA, and all those highly qualified and validated journals in the field of medicine. So I will be sharing stuff from experts, from this and that, who's the proponent of this vaccine, who's against this government, there are a lot of references that you can see all over. It's widely spread. And I tell you, it's very important to filter our references, our sources, because as what I've said, even doctors, even PhDs, even well-known medical experts have also veered towards anti-vaccination, and that's very sad. In fact, I have I want to share a very sad story about one of my colleagues in the research field. If you have heard about Peter Maklo, I know some of the people have shared links about him telling people about the danger of vaccines. In fact, he was a co-researcher of mine in one of our meta-analysis papers. If you remember about the ACE2 receptor, so we studied about African Americans because the question was raised about whether COVID-19 is worse in African Americans. When I said that, it's because African Americans have POL2 gene mutation. They have this ACE2 receptor mutation. That's why they do not respond well on medications like captopril, enalapril. Any medication that acts on ACE2, they do not respond well because they have a mutation in the ACE2 receptor. And we were thinking, can they be protected from the COVID because they have the mutation? So that was the question that pushed us to do research. Or should we hold medications acting on ACE2 receptors? Just like what I've said, those medications are very important for hypertension and heart failure. So those were wonderful questions, and we did meta-analysis studies on that, and he is a co-author of mine for that study. Apparently, I'm seeing his face all over the media, and I was so shocked, his tone is veered towards anti-vaccination. And he was talking about side effects of the vaccination, and he even published one paper last January about pushing for measures to intervene mild or asymptomatic COVID. And I really appreciate that. Right now, we have papers coming out, we have studies coming out about how to intervene the early part of, or the early course of the COVID. By the way, COVID is a disease caused by SARS-CoV-2. Okay, so the virus is SARS-CoV-2 and the disease is COVID-19. So don't mix them up. So it's very sad because when I saw that, I was like, oh, he's a co-researcher. He's a very famous guy. He is the president of Cardiorenal Society. In fact, now they're thinking of replacing him because of that. So I talked to the vice president of a Cardiorenal Society in the USA, who is a direct mentor of mine. She's in India and she published more than 400 to 500 papers. And I talked to her about it. Like, what's your opinion on it? And very sadly, she said, that's the reason why I'm not working with him anymore in our future researches because of that. And she said, that's why be very careful, because even the most intellectual can actually, fall through the trap. So I'll be sharing with you facts about, is this really real? The proximal origin of SARS-CoV-2. And to shorten, this is a Nature Medicine journal, they're saying that this virus appears to be optimized for binding to human receptor ACE2. They're highly optimized, specially optimized to bind to our receptors. And it's almost impossible to make a virus that would predict what receptor to bind to. And the spike proteins, as what I've highlighted here, I know you can't understand this very well, but it's just enough to say that these spike proteins are functional, a result of cleavage sites. There's specific cleavage sites in that spike proteins, which actually lead to the acquisition of specific glycans around the site. And those evidences proved that this SARS-CoV is not a laboratory construct or purposefully manipulated virus because of that. And they have concluded that this specific modifications of the spike proteins would actually result from either a natural selection in the animal host before human transfer. When I say natural selection, I would put it this way, like survival of the fittest. Viruses, they can survive in a certain environment if they have the capability to survive. So there is natural selection in the animal host before transfer to human beings. This is only the possible explanation why you had all of this highly specialized characteristic of the spike proteins, or there is natural selection in human beings following the zoonotic transfer. When I say following zoonotic transfer, after transferred from animals to human beings, then the mutation happened, or the mutation happened in the animals before transferred to human beings. Those are the two possibilities. And that's the only possible way for these specific two changes in the spike proteins to happen. So it's not possible to create them in the laboratory. No, there should be transfer from animal to intermediate host and to human beings. In fact, this is the reason why we're seeing a lot of variants. If you've heard about alpha, beta, gamma, delta variant, you've heard about this. And you would think of, oh, what's the reason? Are they making this up? No. So there is mutation, just changes in the spike proteins that would give you the name of different variants. And this is because of a jumping mechanism. Once the virus jumps from one human being to another, jumps to the animal, back to the human being, then we have all of these changes in the spike protein. So, bottom line, as long as this virus exists, as long as this pandemic prolongs in duration, then we cannot stop this virus from mutating. That's why it's very important to suppress this virus. And I will tell you later why do we care? Why do we care? They would say, the fatality is very low. When I say fatality rate, how much this disease can cost, I mean, the propensity of the disease to cause death. Is it as bad as Ebola? No. It is as bad as dengue? No. But you will see later what I am talking about. And that boils down to this SARS-CoV-2 virus as an RNA virus. So we can have DNA and RNA viruses. Unfortunately, these RNA viruses don't have proof reading capacity. I know some of us here have master's and doctoral degree, and even students can relate to this proofreading skill of a person. When I say proofreading, you have to, read again through that and then do some editing before you do the final output, right? So RNA viruses don't have proofreading capacity. That's why if they have errors in some of their basic proteins or like a pairing of the DNA and all this stuff, then they cannot correct themselves. They don't have this exonucleases and polymerases to just cut one specific area and paste it to the another. That's the problem with the RNA viruses. DNA viruses, they have proofreading capacity. That's why you cannot hear about hepatitis B mutating. Hepatitis B is a DNA virus. So that's adenovirus is a DNA virus. So that's why you can surmise that, these RNA viruses can really mutate because of this characteristic. All right. So once this pandemic actually started December, this was the prediction. They said swine flu can just give you this much of death, maybe. This is per history, and this is the flu, and this is the H1N1. You're very aware about it. And then they're projecting that coronavirus. This is early, once this pandemic started last year, they were predicting of maybe around 60,000 to 240,000 deaths, right? But look at statistics now. This is per July 15. They were predicting around 240,000. Look at now. How many deaths do we see? 4 million. And the confirmed cases is 188 million. And the mortality, if you compute that, is only 2.15%. And people would ask, why do we care? It's just 2.15. It's not even 50%. It's not even rabies. Rabies is almost 100% fatality. Once you have the disease, you die. Ebola virus, very high mortality. But why do we care? Why do we care? Do we care about the 4 million? Do we care about 188 million all over the world? And what does this mean? What does this pandemic mean to all of us? We know about this stuff. Look at this. You have COVID-19 infection. You have direct health impact because you see people dying. You see people having the disease, but that's not just about it. Look at this indirect attributable morbidity and mortality. Home isolation. How about that? How about people getting fears and anxiety? How about people getting this, problems, fewer staff in the hospital, exhausting our resources in the hospitals? How about infecting all the nurses and the doctors? How about destroying our health system? How about these restrictions and of non-essential sectors, underemployment, stress and boredom, reduced utilization of walking and cycling? These are just indirect effect of your pandemic. Social disorder, people can't, those people with depression and with bipolar, those people with generalized anxiety disorder, they cannot go out because of these restrictions. How about people losing income because of underemployment and essential services are stretched? You can see here loss of education, children at risk of abuse, you have debt and house insecurity, reduced access to basic necessities. These show that we are all affected, all sectors, because of the pandemic. That's why we care. Just imagine if we lose our healthcare system, who would take care of the other diseases? That's why you can see here some non-COVID care is displaced. People with heart attack, people with stroke, people with cancers cannot go to the center. People with dialysis cannot even have themselves dialyzed because they need negative test, RT-PCR. And how about people who need immediate surgery? They cannot do it. That's why it's horrible. It's a horrible disease. It's an ugly disease, not just because it has low mortality rate, but because there are a lot of people being affected. That's why we care. Okay? And the question is, do we need to do something because it's just low mortality rate? I hear that all of the time. And that somehow irritates me a lot because I can still remember how burdensome it was to take care of these people. At the beginning of this pandemic, I still remember I was a first-year medical resident around February. I was in the medical ICU when I got a phone call from a sister institution that they're going to send one pregnant woman who was intubated at her 34th week of gestation and needs further care because they cannot manage that patient in that hospital. And she's getting transferred via air ambulance. I was like, what am I going to do? I was the one who was receiving the patient. I don't know anything. There was no known management and guideline for a pregnant woman with COVID who is going to deliver. And the patient is intubated. Her blood pressure is tanking and she is on a lot of vasopressors. When I say vasopressors, medications to keep your blood pressure up. And of course, she's intubated. So you expect that she has a lot of sedation. And I said, will the baby be sedated too? Will the baby die with his sedation? What will I do? Will I deliver the baby? We don't know. We were perplexed because during that time, less was known. That's why we do research, and research. We were craving for it because we don't know what to do. There was no algorithm. It was a new disease. We only know how to manage maybe acute respiratory distress syndrome in adults. Yes, we do have guidelines about it, but it's a different population and it's a different disease. And we don't know exactly the pathophysiology. We don't know exactly what medications to give. We were just craving for answers. How do we prevent it? How do we cure it? Research, left and right, research. That's why it's very important, brothers and sisters, to look into research-based guidelines and algorithms. This has been the output of a lot of work put into doing something. And I beg you to really find good sources out of research. We need randomized control trials. We don't need reports. They're important. You start with case reports. I see this, I see this stuff. And then we combine these studies. We have to do randomized controls trials. When I say randomized control, there are two groups. I will not lecture research here, but one group should receive the treatment, one group should not receive, and then we will look at the outcome. If there is a difference, this one died, this one no, we have to look at statistics. Is this significant or is this just occurring by chance? These are questions, that we need to answer. We have to go by the numbers. We cannot just say, one patient died out of 1 million, I won't get vaccinated. I hear this all of the time and somehow it saddens me a lot. Like, I know not all people know about this p-value and confidence intervals, but we have to translate it into layman's terms that, hey, this is what the evidence say. Believe this. This is just made up. This is just because we studied about 40,000 people who got this vaccine and this is the result. Okay, and there are a lot of reviewers before this gets published. We look at the biases, and then if we have questions about data collection, about internal and external validity, then we don't publish them. Once you see a paper come out in New England Journal of Medicine, the #1 journal in the whole world in the medicine field, then believe it. Of course, we have to have critical thinking. We still have to appraise it, even if it's published in NEJM. Our task given as doctors to critically appraise it. Unfortunately, not all of us have this skill. That's why we're here to educate. So going back to that story, we were so perplexed, we were so baffled what to do. Because as what I've said, less was known. So we tried this medication, Some of the medications were experimental, and then we got the answers. But definitely the question is very simple. What should we do to prevent it? Well, it's a respiratory disease affecting primarily the lungs that maybe masks can be done. Then maybe 6 feet of space between people can help. And maybe outdoor space should be limited. That's why you have a safe spot in between. That's why you hear the government telling you, please wear a mask. And all of this, please socially distance yourself, hand washing, and please don't stay indoor as much as possible. And you have the hot spot there, crowded places, indoor space, and you don't wear a mask. And unfortunately, I hear people say, you don't have to wear a mask. Because, once you wear a mask, you'll be suffocated, you will have increased heart rate, and you will have accumulation of your carbon dioxide. Have you heard about it? Right? It's just absurd. I have been wearing masks for the entire pandemic season, and I don't have any issues. But I've heard Filipinos, I have heard about patients here in the US talk about it. Then let's talk about research about it, right? Are these harmful? This is published in JAMA, Journal of American Medicine Association, peripheral oxygen saturation in older persons wearing non-medical face masks in community settings. Are masks harmful? No, look at this. I'm going to show you simple numbers and I will let you know and explain it to you in a very simple term. This is before mask. 1, 2, 3 group of people, their oxygen was like 98, 96, 95, 96. Okay? Their mean, once you average them, is 96. While they're wearing the mask, the average is 96.5. I don't need to compute this for you. You can analyze this. After the mask, the average is 93.6, 96.3, I'm sorry. Is there a difference? Of course, statistically, they will do that, and then they will give you the number. P is equal to less than 0.05. That means there's a less than 5% chance that this is not occurring by chance. And look at these numbers. Look at the heart rate. This one is the baseline without mask. The middle one is those with cloth face mask. And the other one is a surgical face mask. Look at their heart rate. They do not have, okay, for research purposes, you can only say that they're significantly different once you don't see any overlap. Here you can see overlap among the three of them. So heart rate is not different from those people without mask, with the cloth face mask, with the surgical face mask. How about the carbon dioxide tension? People would say, once you have the mask, you will accumulate CO2, you can die. It's absurd. Like, what are you saying? Why are you making this up? This is ridiculous. And people would say, don't wear a mask anymore. And you hear even Seventh-day Adventists talking that to people, layman people, and telling people not to observe minimum protocols from the government. No, it's so sad. Why do we say those? CO2, that's the carbon dioxide tension. Look at that. There's no difference. Everything is overlapping. How about the oxygen saturation? Everything is overlapping. By evidence, brothers and sisters, masks are not harmful. So if any of you still think about it and spread this lie, stop doing it. Okay? Even if you don't want the vaccine, it's fine. But we have to observe minimum protocols. It's just sad because sometimes I hear Seventh-day Adventists promoting people, like telling people not to follow this protocol, thinking that they know better than the experts. Ano ako ginaingnusahin no daghan kaig bright sa Pilipinas, unfortunately. Usahay magpa-bright na lang, no? So we have to know what we're saying, and I'm happy to share that with you here, but I don't have any judgment. I don't pass any judgment. Now the question becomes, what can we do for preventive purposes? We're just talking about, curative, in the social media, in your researches, what to do, what not to do. But right now, like maybe 2 days ago, came out this paper in NAJM, and these medications are monoclonal antibodies that are shown. You can see here, this red line, these are symptoms, okay? And these are the days that you see. So a very small amount of patients actually have symptoms once they receive this compared to those who did not receive these two medications. So this is now being applied, or this being distributed here in the US, bamlanivimab plus the etesevimab, which are very expensive drugs. But my purpose of this presentation is just telling you that we are currently doing research for preventive purposes as well, like to manage asymptomatic and mild COVID. Because sometimes we're just focused on the severe ones, what to do with the intubated, what to do, with people that require oxygen. And I will present to you later. Some people would say, oh, ivermectin, there's an evidence out there. And why is it not used? Some government officials in the country even endorsed it. And they would say, DOH is crazy. They're not endorsing this. This is just, everywhere. Why can't we use it? Because we have to follow, evidence-based. We have to see randomized controlled trials, good studies to say that these medications really have benefit and they don't have side effects. We do not just go by case reports. These 3 people got better with ivermectin, You have a randomized controlled trial. I even saw one randomized controlled trial of inhaled budesonide. And when I saw, it's just 140 people. Like, what? You will generalize in the whole world with 140 participants? So it's not even enough to just look at the conclusion. You have to read through the paper and critically appraise them. This one is a very good one. And we're trying this here Once I see patients in the outpatient with COVID-19 and they're very, very asymptomatic, meaning they don't manifest symptoms. They're just like walking, talking. They're just carrier that they can isolate at home and be given this medication. All right. This is actually the encouragement of Peter McCullough, the one I was talking about, like pushing for interventions in the asymptomatic and early phase of COVID-19. And this is one of the answers. If you have heard about hydroxychloroquine and azithromycin, these are the first medications that we tried. That's why I'm saying, research has really helped us in managing patients, because we now see bigger numbers, a lot of patients being given this, and what is the effect? So this is also a very good lecture for medical doctors out there treating people, and sometimes unnecessarily treating people with hydroxychloroquine. So it says here that even in combination, hydroxychloroquine for malaria and azithromycin, just an antibiotic for your usual, pneumonia, do not improve clinical status at 15 days. That's why we stopped using it. If you're still using this one, think about your guidelines in the hospital and talk about it with your case manager and your medical directors, okay? Dexamethasone, this is one of the things, the cornerstone of what we do. Because as we see here, this can result in 28-day mortality. So right now, once the patient requires oxygen, that's our parameter to say, let's start the patient on dexamethasone. Regardless where they are, they may be in the ward, maybe be in the step-down unit. That's the middle ground between ICU and GMF here. GMF, I say, was ward. And once the patient go into the ICU, then they can still receive from dexamethasone intravenously, IV. And we can give it for max of 10 days, okay? If they have mild symptoms, maybe 5 days would do. So this is evidence-based. How about remdesivir? We use it, remdesivir, for treating COVID-19, but the only effect is just shortening the time to recovery. There's no evidence that remdesivir can decrease mortality, only dexamethasone. You can just say shorten the time of recovery. When I say that, maybe 10 days of hospitalization would go down to 5, and it's significant. That's just the purpose of remdesivir. And how about tocilizumab? We initially used this very expensive monoclonal antibody in the beginning, because of course, as what I've said, everything was experimental, everything. We do not just play with patients and experiment on them, but of course, before these medications came out, of course, we have preliminary findings. We know about their mechanism of action, and we theorized maybe this could help. But we see that this did not result in significant better clinical status or lower mortality. No result. So if you go to the hospital and they treat you with this, rethink about it. Talk to your doctors. Doc, I know that in one of the publications, that this can not result in any significant better clinical status. So maybe you can spare yourself from 30,000 of one dose of this there in the country. And here we go about ivermectin. We heard about this. I've read about reports, different reports, even doctors posting in their Facebook about ivermectin. And I was so surprised, like, what? Even doctors post this? And I read through some of the papers that they have posted in their Facebook. I just feel sad because most of the papers are pre-published, meaning they're not yet peer-reviewed, and yet they're pushing for this. Very, very saddening. Why? Especially in those who, in my profession, like we're all graduates of MD and we know about research, but people have come to believe in, unvalidated. Why would you publish a pre-published paper and tell the people to use ivermectin? Okay, you should know better. But this is a randomized controlled trial that's published by JAMA in 2021 this year. And when I say randomized controlled trial, that's what I was telling you. Like they give medications and then they follow through patients and see their outcomes. It's not just retrospective. It's not looking back. No, it's moving forward and seeing what the results and outcomes would be. And among mild COVID, a 5-day course compared with placebo. When I say placebo, that's nothing. You just give something that maybe water or nothing. It could be a standard treatment or really no active ingredient there. Did not significantly improve. That's the reason why it's not being pushed by CDC and WHO, because we have randomized controlled trials, good studies with good methodologies that doesn't show there is an improvement. So if you heard about this all around the media, no, not yet. I'm not saying there is no possibility. There could be trials coming out in the future that would say, oh, we see a large group of people, we are, we included this maybe 20,000 or 15,000 or I don't know, and then they would show improvement with the status of COVID, then go ahead. I'm not saying this is the end of the ivermectin, but who knows? But at this point, there is no advisory yet because we don't see any robust evidence of it against COVID. And then here we go. This is one of the newest, baricitinib with remdesivir. And then you can see here, baricitinib compared with your remdesivir showing you some median time of recovery, 7 versus 8, it's just 1 day. Time to recovery, 10 versus 18, and serious adverse events, 16% versus 21. This is now being distributed because somehow it gives you some lesser serious event with median time to recovery better, but see, it doesn't have any mortality benefit. The only one with mortality benefit is dexamethasone. And when people ask, how about steam inhalation? How about tuub and all these things? I'm not against them. You can use them. Just make sure that you are safe. But if you think that's the only cure, then something's wrong. You can do it preventive, maybe. That's why if you have symptoms, if you feel like you're short of breath, and you can't take it at home, please go to the hospital and seek professional opinion. Now the question is, why do we vaccinate then? Is it necessary? That's part of prevention. Okay, so primary prevention, we know that. We have to make sure our immune system is okay. We do a new start. That's always the starting point all the time. Primary prevention, before you get the disease, do something. Okay, that's primary prevention. And vaccination is also part of it. Before you get the disease, do something about your immunity. And people would ask, is natural immunity not enough? Is new start not enough? Right? People have these questions. Do you trust God less with your immunity when you get your vaccine? These are common questions all over the social media. And I would like to answer them. No? If you answer them with this background, this is just maybe in UK. Yeah, this is in UK. Look at the cases from diphtheria after the initiation of vaccination in 1940 until now, 23 until now. You see this plateau coming down, almost zero. You have here meningococcus. You can see the downtrend of all these diseases that's highly preventable by the vaccine. That's why we vaccinate, because we don't want virulent diseases to actually take a toll on the health of the people and cause pandemic. And if you can see here in my next slide, why do we need the vaccine? This is your vaccine exposure. Here at the beginning, you have antibodies response. Antibody is actually a response that our bodies produced to actually attach to an antigen. Antigen is something, any foreigner in the body, any invader comes in as an antigen, that would elicit your body to produce antibodies. So this is the response of your body. First, you have to have a memory of this. You have to have a memory of that specific invader. So by the time it comes back again, then I have group of armies specific, dedicated to that specific invader. And then when that specific invader comes again, I have a better memory and I can mount a better reaction. This is the purpose of your vaccination. Now, people would ask, can I just, natural immunity would be enough? I can have this once I have the disease, then my immune system can actually produce my antibodies and kill the virus? Yeah, there's no problem with that. But the thing is, if you are perfect, if you're in perfect health, like you do new start each day and you don't miss, you're sleepless like what I'm doing right now, So there are many instances that somehow our perfect immune system is not achieved. We do not live in a perfect world. That's why we need something to boost and to give us specific antibodies. specific. When I say specific, geared towards a specific invader. There's no such thing as non-specific antibodies. I've heard about it also. Like people who pretend they know something in medical field, they were telling about non-specific antibodies. Your immune system can do this because God is with you and all these things. No. There's no such thing as non-specific antibodies in the world of immunology. It has to be specific. A certain antibody cannot act on a certain invader. That's what I've said, if there's no lock and key, no, they cannot attack. They cannot produce the reaction. It has to be very specific. That's why you have to have the vaccine, because you will expose yourself to a certain spike proteins and your body would say, oh, I have this invader, I will produce a certain antibody, and once the real one comes, then I can fight. Now, it's very important about stages of vaccine development. We should know about this, because I've heard one doctor who said, oh, this should be done in an animal trial. Why is it done on humans instead of animals? Like what? You forget about vaccine development already in your pharmacology in second year of medicine? People get misled about stuff because they stop thinking and they just believe whatever is in there in the social media. Now, there are different stages of vaccine development. This just come out there for like, oh, out of the blue, we can give this to you. Try this experiment, and if you die, you die. If you don't, then you're lucky. No, it's not like that. There are preclinical studies. How will this vaccine work? When I say preclinical studies, they're applied to non-humans, maybe a rat, call them laboratory animals. They have to know exactly how the medication works. And I forgot to mention here in my slide what we call vaccine-induced disease, meaning the vaccine can cause the disease. Once they see that there is a potential for vaccine-induced disease, then they stop in the preclinical stage. They just stop. The FDA is very strict about it. Safety protocols, stringent measures are applied in each phase. If they fail in one phase, they cannot go to phase 3. That's why if you see your vaccine passing phase 3, it means they underwent through the preclinical studies in animals, and they see, oh, there's no vaccine-induced disease potential, meaning the vaccine cannot cause the disease, then they proceed to phase 1. And the question with phase 1 is it safe? I will try 10 to 100 healthy individuals. And then if they see, oh, it is safe, there's no vaccine-induced disease here, then let's go to phase 2. Again, the question, is it still safe? With a bigger number of population, maybe 100 to few hundreds. And what's the right dose? I'm sorry, I forgot my question mark here. What is the right dose for this? And then once they pass that phase 2, they go to phase 3. Now the question is, how effective is the vaccine? You heard about efficacy rate. That's why you hear all those percentage, 74%, 80%, 94%. Actually, you cannot compare one vaccine from one vaccine to the other, because they're using different platforms. When I say platforms, they can be inactivated, they can be vector vaccine, they can be mRNA, and they're experimenting. And the participants are also different, like different people, different time. So you cannot really directly compare them, but at least you have an idea that the efficacy rate would tell you. If it says 96%, you have a 4% chance that you can still get the disease. It's not 100%. You cannot identify any vaccine that would give you 100%. It's always less than that. And we're just happy with above 60, even above 50, 60. If we see 74 for AstraZeneca, 80% for that, 96%, way better. But as what I've said, there's no point of comparison, because the background, the setting, the participants are all different. So is it ready for the world? Phase 3. And now most of the vaccines are in phase 4, because they're already applied in thousands. But if you remember about the Moderna and the Pfizer, phase 3, they used almost 40,000 participants. And most of the vaccines actually go through maybe 1,000 to 2,000. And that's a huge number. And really you can say, ooh, something is very good here. 20,000 in one group and 20,000 in one group. And then you combine the numbers and you see how many people get the disease when they received the vaccine, how many people got the disease when they did not receive the vaccine, and then you compute for the efficacy rate. Phase 4, will it stay safe down the road? That's the question that we're looking at right now. And to give you an idea how many vaccines out there are being evaluated by the World Health Organization, you'll be shocked. 108 in clinical development, 184 in preclinical development. You're only seeing few, can be counted by the fingers. These are rigorous processes that the FDA is putting a lot of, safety protocols. And people would ask, oh, anong paspas ang kain ng uban nga vaccine? Right? It's not approved. So I will discuss later the differences of that. But, because of this pandemic, this calls for a rigorous and a rapid evaluation, but that doesn't compromise the safety protocols that was set. The standards, the integrity is just the same. Sometimes you can have overlap with the phases, phase 1, phase 2 overlap, just to make sure that we could have a speedier, development or production of vaccines, and we can have the data. Even then, all this data will be evaluated by independent reviewers. People would say, ang katumahong nag-fund sa maura po na no, there's no such thing as that. Before it gets published, analyzed, there should be independent reviewers, not involved, with, conflicts of interest are actually declared when we do that, when we evaluate papers. The introduction would say, I have evaluated several papers in the journals, and that should be our focus, biases. We have to address all of those. And here we go. We're dealing with the stuff about, I would like to simplify these things for you. How do we approach, making a vaccine? You can probably get the genetic material here. You can probably get some part of it, the virus, or generally the entire virus, and just attenuate it or maybe inactivate it, just so when the virus comes inside the body, it doesn't cause the disease, but it can elicit an immune response. These spike proteins, remember them, that they're the key features of a vaccine to induce our immune reaction. This is a very nice summary of all the vaccines in the Philippines. Okay, because in the US we only have Pfizer, J&J, Moderna, and Novavax approved by FDA. I think in the Philippines these are all approved. Okay, sorry, authorized. I would say authorized. Emergency use authorization is being used during the pandemic, so we could use something, but approval is different because it has to go through certain number of years, and we see the result of the phase 4. That's why you cannot call it approved yet, but it doesn't mean it's less safe. The same protocol, the same safety measures are applied. So what I've said here, you have the Pfizer mRNA, those are genetic materials. Also same with Moderna, they share common platforms, which is the first platform to use mRNA in history. But the mRNA technology has been there for quite a time already. We use that in treating cancers, targeting malignancies, and also, if you remember the SARS-CoV before and MERS-CoV, the concept was already there. It's just that during that time, wala na sila nahimo, or the disease just died down, so wala na sila na-approve, wala na come into fruition ng ilang mga efforts for this vaccine. But they have an idea already. They have already the concept how to do it. That's why it was quicker this time. So mRNA, and then we have here inactivated virus. Sinovac, Sinopharm, those are inactivated virus. The entire virus is inactivated, and they do not produce the disease itself. They come inside the body, they're injected, and the body actually responds to the spike proteins that they see. And also we have here AstraZeneca. You have a viral vector. It means that the spike proteins are being carried by the separate virus. It could be an adenovirus, but they are non-replicating, meaning once that vector is something that carries. It's just like, maid in a home, an assistant, something that brings something to the master. It's like that. So a different vector actually brings the cup, that's the spike proteins, and then gives it to the master so that the master can produce something against the cup, something like that analogy. But the maid cannot replicate itself. That's non-replicating viral vector. Same with the Sputnik that I think was approved and was authorized there. Also, same with Johnson. And the protein subunit, I don't know if it's available there already. It's a Novavax. This is one of the newest here that was just approved by, authorized by, I'm sorry for the word, authorized by FDA. And this is the protein subunit, meaning the subunit of a protein, a spike protein is being used. As you can see here, age group is now authorized for less than for 12 and above for Pfizer. This is based on newer trials that came out. Most of them are like 18 years old and above. Okay. And the doses, I don't have to mention them. And the efficacy, you can look at this, 95%, 70%. But as what I've said, you cannot compare one vaccine to another because they have different settings. As long as they're above 60%, I'm good with that. And the most common side effects are just local. Injection pains, maybe fever, maybe headaches. And we will discuss later the safety. Like people would think about, oh, somebody died from this. Oh, somebody had a heart attack. Oh, somebody had this thrombosis. I want to get the vaccine and all. Oh, and we will discuss that later. I'm almost done, by the way. And this is a very controversial issue, right? mRNA vaccine and the DNA. I even posted one thing about it because it really irritated me. Like, how can an mRNA vaccine alter your DNA? Maybe a virus, SARS-CoV, can. We are seeing some evidence right now that the virus itself could enter the DNA even if they're just RNA. That's why this is a speculation only. We are doing trials and studies on this. If you remember, like people having COVID before, like months and months, and there's a positive, turned positive for RT-PCR, right? Or I have COVID like a month ago and I'm okay already. I'm cured. But when I do my RT-PCR today, it's positive. There's a possibility that maybe it could be a remnant of the virus. When I say remnant, bilin ba part sa imong virus ang mRNA ang genetic material can still be detected by RT-PCR. Or the virus could have gone through the DNA and still produce spike proteins, and mRNA and spike proteins, okay? That's a possibility, but that's not proven yet. But I'm talking about the virus itself. I'm not talking about the vaccine. The vaccine cannot by all means, no feasible means or mechanism can this vaccine go inside the nucleus. Why? First reason, mRNA vaccine is a naked genetic material. Naked, you understand this. It's naked. Once they come inside the cytoplasm, you see this colored brown, I would say, maybe light yellow, brown, colorblind. So this can come inside the cytoplasm. This is the cytoplasm of the cell, and this is the nucleus. I'm sure you still remember this in your biology. They are separated by this nuclear membrane around it. No one can enter that without specific nuclear pore complexes. No one. Nothing. God is so wise that not anything that comes to the cytoplasm goes inside the DNA. If that happens, we're all robots now. Robots, I would say. We're all cancers now, if that would happen. Why? Don't tell me all RNA viruses, whenever you get cold, it's like a common rhinovirus, goes inside the DNA and affect your DNA. Now you are all cancers. We are all cancers now. Each time it goes inside, it mutates your DNA. And all mutations, any kinds of mutations, can alter your DNA genome and then can change you as a person, can change dictation of the cell, everything is messed up. No, that doesn't happen because our nucleus is so well guarded. And even inside the nucleus, you have a nucleolus. Okay? So once the RNA virus comes here, it cannot go inside. I'm talking about RNA virus. But if we're talking about the vaccine itself, they're naked material that once they're exposed in the cytosol, there are a lot of enzymes there that can degrade them right away, even hours, maximum of hours only for COVID vaccine. Musulod pa man in taon siya dito nga, diri pa lang, they can be deactivated right away. That's why once they're injected, they immediately translate into proteins and spike proteins. That's always our goal, right? We've talked about it. That's our goal, to produce spike proteins and expose it in the surface of the cell. And then our body sees that spike proteins. Oh, na ako yung mga kalaban. I will produce something against it. And then once the real one comes, then I have a memory. I have all my soldiers already, then I can mount the response. Okay? So it cannot enter, the mRNA vaccine cannot enter because it's well guarded. The vaccine is naked. It can be deactivated right away there for hours. Second, it has to have a lot of, this is what I'm telling you again, lock and key. They should have a receptor. They should have something to go inside. I cannot explain this thoroughly, but you should have importance protein. You should have those basic proteins, complexes to enter the nucleus. And once you're inside the nucleus, you have to undergo this reverse transcription. DNA goes to RNA by transcription. If you want to convert RNA back to DNA, you will need reverse transcription processes. And it needs another specific enzyme, right? That is well studied in retroviruses, in HIV, okay? If you heard about it, retrovirus, that's why they're called retrovirus, because they can induce reverse transcription. And mind you, I've heard a doctor saying that mRNA, that coronavirus is a retrovirus. It's not. Sadly, it's not. Retrovirus, most of them, HIV, they're HIV, they're not, coronaviruses are not retroviruses. They don't possess reverse transcriptase enzyme, okay? But our human body has reverse transcription capacity, okay? We have retrotransposons. We have 4 elements. I will not discuss in detail what are they, but we have the reverse transcription enzyme. But the question becomes, Doc, is the mRNA vaccine, can this be transcribed back to DNA? My first question is, if it can go inside the nucleus, maybe. But in the first place, it cannot go inside. The reverse transcription only happens inside. And this enzyme of ours has to be very, very specific to a certain agent. It has to have a primer. May mga primer diha before na. Pagod magsa movie na mga premiere. It has to have a primer before our retrotransposons can act on certain genetic material. Unfortunately, that's what I've said. mRNA cannot go inside. It's easily deactivated outside. Once they go inside, starting the 1 out of 1 billion possibility, nakalusot dito sa sulod, it doesn't have any primer to initiate reverse transcription. That's why I'm telling you, the possibility is almost zero. So if you're afraid about mRNA vaccine affecting your DNA, please remember this topic. Remember that discussion. So this is it. That's what I've been talking about. Emergency use authorization. People are scared. I authorized naman, dili na siya approved. That's what I'm telling you. Still, we do this because of the pandemic. If it were that without the pandemic, then we don't have to do this. We don't have to do EUA. We need approval. But unfortunately, we are in this pandemic. Understand that. Rigorous standards set forth with the DNA is not by FDA is not compromised. We prioritize and speeding the development because of the pandemic. That's just the reason. I hope you understand that we are in the pandemic. That's why we emergently use some vaccines that we see benefits more than the risks. That's why there's no approval word there. Now, this is the big issue. Doc, what about safety and side effects? Most of them have local injection site pains, fever, and malaise. Some of you are vaccinated. You can attest to that, right? I was vaccinated with Pfizer. I feel like my arm, I cannot move my arm and lift it, above 90 degrees for the first 24 hours. But eventually, just after 24 hours, went back to the hospital. And then you see this COVID-related deaths more than COVID vaccine-related deaths. Okay, remember this, vaccine and COVID. Mas daghan mga kaisuunan ang COVID-related deaths compared to your COVID vaccine-related deaths. And even those deaths, I put a question mark here because if you read papers, we haven't established causality. When I say causality, one factor is the cause of a certain outcome, like directly the cause. You have to establish that before you say that death is related to a COVID vaccine, not the COVID itself or other causes. I will share one experience with you. There was one post in Facebook about a father in the beach. namatay after getting the COVID. Maybe AstraZeneca, I don't remember, that the patient tested for COVID, positive siya sa RT-PCR, and then eventually died from the COVID complications. And now they're thinking that it's from the COVID vaccine. If you think about it, AstraZeneca will never test positive in RT-PCR. Why? Because RT-PCR only detects genetic material. And remember that AstraZeneca is not an mRNA. Okay, so we have to make sure that the deaths are actually caused by the vaccine and not by other causes. I'm going to show you later statistics, of what are the possible causes of deaths related to the maybe administration of the vaccine, maybe anxiety related. I will show you. There are only 4, like in Pfizer, and it's very interesting. There are more COVID related deaths. That's why I'm telling my patients, aren't you afraid of COVID itself and getting intubated versus all this injection pains? I don't know how people would believe in all of this reports sent by somebody, anecdotal reports, news all over the media, news that are fake news, like pretending that they're reporting in front of the TV. And then when you read up and when you really listen to them, 4 minutes of 5 minutes of talking about one topic? Is that real news? People have to be discriminatory, but I think somehow we lost our ability to think. But I'm challenging you here. We have to weigh things, benefits against the risks. Look at this. J&J and Guillain-Barré syndrome, like those paralysis, ascending paralysis, 100 cases out of 12.5 million recipients. Look at this. Even without the vaccine, we can have these statistics, even higher than this. Bisag wala ng vaccine diha, bisag ang natural statistics lang sa usa ka disease. How about heart inflammation from Pfizer and Moderna? 41 out of 1 million. If you can calculate that, what's the possibility of you getting it? And even without the vaccine, you can have more than this cases. How about thrombosis, meaning clotting, blood clot? You hear about this. AstraZeneca can cause blood clot in the brain and all this stuff. 126 out of 34 million. And if you hear about anaphylaxis, like, swelling of the lips, and then they died after the vaccination, 1 out of 1 million. Now, that's why I'm telling you this word, causality. Is this one case really from the vaccine or no? We haven't proven that. That's why these numbers speak for themselves. Like, think about it. If you hear those reports, then look back at the statistics and compute if it's really true. So this is just from Pfizer. This is from publication from NHM. Look at this. These are local injection site reaction, and these are fevers. And if you can see, most of the reactions are from the younger people because they can mount a stronger response. That's why they have more pain and all this baby. That's why we're saying, the adults are even stronger than us, but it's not like that. It's because that our immune system are more robust in the 60s and above. That's why you're seeing those more local reactions. And see these COVID events, adverse events. According to Pfizer, there's no COVID-19 associated deaths were observed. If you can look at this, just look at the numbers. How different are they? This is from the Pfizer and this is from placebo, meaning no active ingredients. 21,000. Look at this, deaths. There's even 4 deaths in placebo and 2 deaths in Pfizer. Look at other numbers. They're like up and down, but they don't see any relationship with the COVID vaccine itself. So these are the numbers that you will see. Benefits versus harm. If you take a look at this, these are the benefits that you can get versus the harm that are minuscule in number. That's why we think about it. Like, will this be authorized? Yes, because there is potential benefit over the risk. More than just magtunga lang ka dira, magtanaw ra ka sa mga cases until all the hospital systems are overwhelmed and we are left with deaths left and right. So this another question that maybe you have, in your mind about pregnant. So we have preliminary findings. This is not the final findings yet for pregnant people getting mRNA vaccine. I'm speaking about Pfizer and Moderna. And you can see here, they are comparing published incidents of those without the vaccine and with the vaccine. Look at the numbers. Spontaneous abortion, a little bit higher here, but not significant. Preterm birth, 9.4 before this. Sorry, and this one, small size for gestation age, like small babies, almost similar. Congenital anomalies, almost similar. And neonatal deaths, almost similar. So they're saying this is 10 to 26 versus 12.6. This is even higher here in published incidents compared to the vaccine group. So they're saying that preliminary data, okay, that there is no safety issues with mRNA vaccine being given to pregnant people, okay? This is just a preliminary data. That's why myself, I wouldn't for pregnant give this because I don't see any robust evidence yet, although they're saying that it is safe. But it's still in the discretion of the patient and their OBGYN. But if they were to ask me, I'll just wait for some better and stronger data. And hear about adolescents. People would ask if you hear about over the media, oh, nga nang experience ang mga bata, nga nang mga buntis apil-apilot pag yun, you know? The reason behind this is they're highly compromised. I mean, they're a vulnerable population too. And later I will show you one of the limitations of our treatment is because we do not include all of them. We have to think about generalizability of a certain study. Like, can this be applied to a certain group? So kung a certain group wala na appeal sa trial, then that certain vaccine cannot be given to that excluded group of population. So here, this is for Pfizer. They included 12 to 15 years old, and they showed some favorable safety profile, greater immune response, and highly effective. So meaning they look at the safety profile of these people, and they say they can be given. That's why you hear, as what I've shown you, TOH there in the Philippines has used 12 years old about for Pfizer. And about the variants, so alpha, beta, gamma, epsilon, all those, and the delta, the most famous now, variants. What are these? I'm telling you, this is the reason, this is the outcome of this virus prolonging in our environment, jumping from one host to another, acquiring all those mutations, and the spike proteins don't look the same. Mura siya og kanang tree ba, nga daghan og branches. Sometimes, one branch, ang isa ka tree, mas daghan, ang isa, deformed, ang isa ka leaf. So, it's just a matter of, alteration with the spike proteins composition. That's why you have different variants. Some variants could be easily transmissible, meaning they can be transmitted to one person or another easily than the previous, like the original SARS-CoV, or sometimes they're more infectious, they're more virulent, we don't know. But we're seeing a lot of variants right now from UK, from South Africa, from India. And remember this reduced the risk of additional variants. What can we do to prevent? See, we have to promote public health measures, the same stuff, and avoid the use of treatment with uncertain benefit. This is what I'm telling you. You cannot just prescribe anything because somebody told you, somebody shows you ivermectin, somebody's, you cannot just do this because if you keep doing this, then we will drive the evolution of more variants. We have to know what are these variants, where is this coming from, so we can target them by research. Trust science, my friends, because God could use science and scientists and us people to actually help. And consider targeted vaccination strategies to reduce community transmission. That's why we're doing this vaccination, because not only for ourselves, but for everyone. You can be healthy. Once I get the COVID, I may not manifest symptoms. Yes, you can be asymptomatic, but that doesn't mean you cannot transmit to others. And what if that unfortunate recipient of a virus is your grandmother who was immunocompromised and died because of you? Kaya na nimos imong konsensya just because you're very selfish about your new start and I can do this, If there's one thing that I learned with this vaccination, I think I have trusted God all the more because, He is using people to actually inform us better. But sometimes most of us are just trying to pretend we know, and yet we really don't. That's why I'm encouraging everyone to use reliable resources before we come to a conclusion. And what's known about the vaccines? I would admit this. We don't know, phase 4 trial results. I don't know when that would come out. We don't know about the duration and protection from the disease or from the vaccine itself. Some people would say 6 months and 12 months protection. People would even say maybe we need booster doses. And we don't have any subpopulations like the pregnant, the younger ones for other vaccines. We don't know those. And we don't know if we have definite protection against new variants with the vaccine. But there are evidence, growing evidence, but I haven't seen published papers yet, how much protection we can get from this vaccine. But it shows maybe there could be protection. Maybe you can be protected from new variants. If you are vaccinated, you can have less symptoms. Maybe you will be asymptomatic. We don't know. But at least you have something in your body, an immune system. You have sets of antibodies to protect you if ever that comes. I hope not. And I think that's it. John 9:67, when the Lord has spoken, he spat on the ground and made clay of the spittle, and he anointed the eyes of a blind man with the clay and said unto him, go wash in the pool of Siloam. He went his way therefore and washed and came seeing. God can use science to perform miracles. I hope and pray that we continue to pray for one another, safety for one another. I have given you facts, not speculations and theories, and it's up to you to believe me or not, but I'm hoping, praying that somehow we can go back to normal. I don't like the new normal. I want to go back to the old normal where we can mingle with one another and worship together without restrictions. I hope this virus will be gone away. Much has to be studied yet, but we have to cooperate. We have to become blessings to our community. Please don't share and spread lies. By doing that, you could, compromise the health of maybe the life of a loved one or a person sitting beside you. So trust the health authorities, trust God all the more, and God bless everyone. Happy Sabbath.
Okay, thank you so much, Doc Pilayo, for enlightening us this afternoon. Very informative.
Yes, indeed. But we need you to stay because we will be answering your questions that you posted in our comment section. No? So if you still have more questions, you may comment sa atong comment section so that we could address them later on. Daghan-daghan taog questions for this afternoon. In fact, I also listed my personal questions about the vaccine. But before that one, you'd be having or pausing for a short intermission number. We have here with us Kyle Talibong, Curvy Rosas, and Uriel Jesper Del Ingod to give us an intermission number. And then we'll be back for the question and answer.
A good night hug. He calls me dad and I call him bub. With his faded old pillow and a bird named Pooh, he snuggles up close and says, I wanna be like you. I tuck him in bed and I kiss him goodnight, tripping over the toys as I turn out the light. And I whisper a prayer that someday you'll see he's got a father in God, 'cause he's in Jesus in me. Lord, I wanna be just like you, 'cause you wanna be just like me. I wanna be a holy example for his little eyes to see. Help me be a living Bible, Lord, for his little boy can read. Lord, I wanna be just like you, 'cause he wants to be like me. We never so far to go, make so many mistakes, and I'm sure that you know. Sometimes it seems no matter how hard I try, with all the pressures in life, I just can't get it all right. But I'm trying so hard to learn from the best, being patient and kind, filled with your tenderness. 'Cause I know that he'll learn, someday he'll see, and the Jesus he finds will be the Jesus in me. Lord, I wanna be just like you, 'cause he wants to be just like me. I wanna be a holy example for His innocent eyes to see. Let me be a living Bible, Lord, where my little boy can read. I wanna be just like you, 'cause He wants to be like me. Right now from where He stands, I bet, but I know of Him from the best Father of them all. Lord, I wanna be just like you, 'cause You want to be just like me. I wanna be a holy example for His innocent eyes to see. Help me be a living Bible, Lord, where a little boy can read. Lord, I wanna be just like You, 'cause He wants to be like me. Lord, I wanna be just like You, 'cause He wants to be just like me. I wanna be a holy example for His innocent eyes to see. Help me be a living Bible, Lord, where a little boy can read. I wanna be just like You, 'cause He wants to be like me. Lord, I wanna be just like You, 'cause He wants to be like me.
Thank you so much, Kyle, Kirby, and Dildil. At this point, we will be answering your questions. The ones, kuan siya, no, I think we'll be taking this in order sa pag-comment ninyo sa ato ang comment section. And so, the first question is, okay, so we have here from Ian Dave Abad. Good day, listening from Digos. If the said virus is constantly mutating, how come the RT-PCR test is calibrated enough to diagnose the viral infection?
So this question is about the RT-PCR. So right now we have specialized RT-PCR to detect some variants, but technically we are looking at the genetic material itself causing this disease, and we are looking into catching more of this Delta variants. This is a specialized receptor that we have to look into. That's why if we do not suspect for variants, sometimes we do not get them. Process on diagnostic testing is also being studied, how we can clinch more of this diagnosis. And the fact that some people actually would get the worse or maybe have the same COVID, like even after vaccination, would make us think that maybe they have this variant or not. But right now in our institution, we don't have it yet. That's why it's geared towards identifying whether they have it or not, and then using the RT-PCR specifically for those variants. So not all of the RT-PCR yet are calibrated for that, but we are moving towards that direction as we are seeing more variant cases around the world.
Okay, thank you so much, Doc. Okay, next question from Judea Swiko. Is it necessary to wear face shield even with face mask on? This is also an issue in the Philippines.
Correct. Yeah, I'm not against using face shield, but of course, the studies that I have shown you is just more on the face mask we have, but in the intimate setting, patients, doctors coming in contact, aerosolizing once they're having this nebulization inside the patient's room, we really use shield because, of course, these droplets could actually be fomite or a means for the virus to get transmitted. But it's more of a protocol, local protocol that will be instituted. Some countries would want to do it for safety purposes. If you do not have a very, very close contact, then I don't see it very necessary. But mask, definitely yes. I'm talking more on intimate, like close contact with aerosolizing procedures. I would really advocate for that, and I would leave that to the government whether they would recommend that or not. If you are very scared about it, just if you're scared more of the COVID, then use face shield. If you're not comfortable, just wear mask and make sure that your immune system is okay. So more layers of protection, the better. But if it would compromise your convenience, then think about the most important.
Okay, thank you so much. We have our next question. Do COVID variants affect the efficacy of the vaccines? So do COVID variants affect the efficacy of the vaccine?
Sure. So I think it's the other way around. The vaccines cover specific variants. So I wouldn't say yes if the variants can change the efficacy of the vaccine. We don't have data yet about it. Like if this variants can decrease, no, because you already have an immune system. You already have the antibodies set for a specific spike protein. So if you have a new spike protein, then that set of antibodies can or may not protect you, but it will not deactivate, it will not lessen your protection. The question becomes, will this protect me? The vaccine will protect me. Will it protect me from the variant? I don't have a definite answer. As what I've told you, there are some preliminary data coming out. They can or they may, but there's no robust data yet. We have yet to see. Yeah.
Okay, Doc. Just a follow-up question to that one, because we're talking about variants affecting the efficacy. The question is, how important is the efficacy or looking at the efficacy in choosing a vaccine? No, I mean,
that's a good question.
What we should be looking at?
Actually, not necessarily, because as what I've said, vaccines efficacy differ because of different settings, different populations applied. But if you were to, what's the purpose of that? Maybe just because FDA needs a certain number before they actually authorize stuff. So they need more than 60%. That's why. But if you can choose a higher efficacy, if you have available the highest efficacy, then just grab it. For example, if you have Pfizer and Sinovac in front of you, then I would choose Pfizer. You know, if you have an option. But if you don't have, then I would say all of the vaccines can be given as long as they're FDA approved or you're authorized in your country, then go ahead. So there's no point of comparison, but I would say practically if you're choosing between two things, then look at the efficacy rate. I don't think there's harm with that, as long as the supplies, okay.
Okay, yes, even according sa atong local government unit, they say that the best vaccine is the available vaccine.
Exactly.
Okay.
Exactly.
Next question, Ma'am Star.
Okay, next question. From Ayan Abad. How can we say that these vaccines are still effective against the new variants if the vaccines themselves were developed prior to the existence of the said new variants? We know that it is medically impossible to predict the characteristics of the mutating virus and provide an advanced vaccine. Is that statement correct? If then, are we getting another more doses? Does it make sense to get the preliminary doses?
Yeah, that's a very good question. So as what I've shown you, the pathophysiology of a disease, you have a receptor, the ACE2 receptor acting on the spike proteins. The effect of that vaccine actually gives you antibodies, specific to the spike protein, to the virus. And somehow, this specific antibodies can actually impact or even kill some of the viruses that come in, even if they don't possess that specific spike proteins. Remember that the spike proteins, they are not everything is, not everything is altered. Maybe one part, the other part is altered, one subunit is altered. That's why they may offer protection. But as what I've said, there's no available data yet. Preliminary data says yes, some of the vaccines can protect maybe 30%, 40%, 50%, 60%. All of these are still hanging on. I don't know still the data, but they may protect, because that's what I've said. The pathophysiology remains the same, and not all the spike protein subunits are altered. So they might probably say, oh, this looks like a little bit similar to the previous that came, that I saw. So that antibodies can probably mount a reaction. If you have a more robust immunity, then probably you can still overcome it. And in terms of the booster doses, that's what I've said, unknowns of the future. We might need some booster doses for a better immune response. We might. I'm not saying we need to and we must. It depends on the necessity and what we see with the data that is ongoing. If we need to have it, then we have to have it.
Okay. Next question. Should we take vaccines for all the diseases and all their variants? What if there are 30 variants of COVID? Should we take 30 vaccines? No, kadaghan.
That's what I've told you. Some of the vaccines could cover some of the variants, and it's still under study. It is not possible to, like, for example, right now we have 5 variants. We don't recommend different 5 vaccines, right? Because as what I've said, it could share similar, phases of the spike proteins, and some of the vaccines could still afford protection. And that's why it's important to even have one protection than nothing, right? We're so scared about the variants. We're so concerned about them. And yet we haven't even gotten the first dose and the second dose, which is ridiculous. Yeah, just get it and then we'll see. Because some people, there are some evidence right now, growing evidence, accumulating evidence that those who have the vaccine at least have less transmission, less infectious, less virulence, and less severe infection. That's just preliminary data it's showing. That's why I did not show that to you, because it's not yet, robust as we expect them to be. But that's not practical. Like 30 variants, 30 vaccines. No, it's not like that. And not all diseases need actually vaccination. There are some diseases, common colds, you don't need vaccination for that. If you're talking about all diseases in the world, and if you're very philosophical about it, no.
Take the first dose. Okay, next question. Is it true that if you are vaccinated with Sinovac, you cannot go out of the country compared with AstraZeneca and Pfizer?
Okay, I think I just have to follow up na lang po ko ani Doc before you answer. Because I have read in the news nga there are other countries that you have to register first before going. Like say for example in Saudi Arabia or in some Middle East countries, nara sila accepted nga vaccines. No? So, preliminarily, that could be answered. Okay, ang ilang dawaton ra dito is kanira nga vaccines. A follow-up to this question is it safe nga, like say for example, naka-Sinovac na ko, tapos, dili man day dawaton sa US. Niya, gusto mo kumatog US? I mean, should I get another vaccine na madawat sa US? Or, is it safe to get another vaccine? Yeah, so we're just a follow-up na lang.
That's a good question. True. But unfortunately, that's not true. For the US government, as long as you're vaccinated, the rule is as long as you're vaccinated, you can come to the US if you have the visa. And then you don't have to quarantine if you're vaccinated, but everyone gets an RT-PCR test. So it doesn't matter if you have Sinovac, whatever, as long as you're vaccinated, you have the ID, you have the vaccination form, then you get the RT-PCR, and if you're negative, then maybe 3 or 5 days of quarantine. I can't speak for other countries though, but in terms of switching, like getting a Sinovac and then getting Pfizer eventually, there's no data yet for now showing evidence of that. But physiologically, I don't see any problem with that. But the question becomes, is the supply enough for you if you have gotten 2 doses already? And if you take another, it's a more of allocation of resources. Because just imagine, Philippines only has 3.5% vaccination rate. That's the most recent that I saw. And we need to have at least 50 for herd immunity. So it's very far. As if you're thinking of switching from Sinovac or Sinopharm to Pfizer and Moderna to come to the US, I think that's not practical. But physiologically, there's no harm with that. Even because I'm saying that because even those with COVID infection, right after the COVID, if they can get the vaccine, why not? To boost their antibodies production. But natural infection is the best immunity you can have. So if you have COVID already, like you have adequate amount of antibodies, it could wane down maybe in 3 to 6 months. That's why I'm saying kung nakasakit ka kag COVID, ipahunod na sa ang bakuna sa wala pa because they don't have any specific antibodies for that. But switching, I don't have any issues. With physiology, it's more of allocation and local, governmental protocols. Like saying they cannot switch, kay daghan pa kay kinahanglan bakuna.
Okay, just a follow-up to that. Because I have heard some nga, ang ilang first dose is kuan daw, AstraZeneca. And then since, I think, gistap man to sa government, I'm not so sure about that one. So nagpa-second dose sila, lahi ang second dose. Is that, now given that, lahi man ni og components ang atong vaccine. There are those katong inactivated virus, there are those which use mRNA. Yeah, is it okay, or could they still get the same protection lahi ang first dose or second dose?
Yeah, that's a very good question. Actually, with the switching of what first or second different platforms of the vaccine, we don't have data yet how much protection you will get. But of course, maybe you can surmise the protection from the first dose is 30, the second would be 30, because we have data, like how much protection you can get from a one dose. For example, Pfizer, the first dose, you can get 50% protection. So if you have Pfizer in the first, and then you got Sinovac in the second, and then the Sinovac would be 30%, you could have 80%. You can say that, but that's what I've said. There's no data yet from one vaccine combined with this. That's why we're not encouraging that, because we don't have data. We don't know yet. But if it's okay, I don't have a definite answer. Maybe, but at least you have a protection than nothing. But in terms of the efficacy, like the real number, I cannot just derive from what we know. So it's okay if that's maybe government may supply issue. But we consider 2 doses even from different platforms. Still, like, you are fully vaccinated. Still, you have the 2 doses, but the efficacy rate I cannot tell.
Okay,
unfortunately.
Thank you so much. Next question. Okay, I have heard 2 vaccine campaigns on people who's trying to conceive. So which is which? Should people trying to conceive get vaccinated or not? If yes, is there a specific vaccine recommended?
Good question. So as what I've told you, the population is very important in vaccine trials. And so we can apply, these people were included in the trial. And fortunately, those people wanting to conceive, they're included in the trial with the vaccines that we have. So you can safely get anything. There's no issue with fetotoxicity. As what I told you, even in pregnant women, it shows like the normal incidences of abortion and all the stuff. It's just similar to those people who got the vaccine. So those who want to actually conceive and get the vaccine, get any vaccine, no preference. You're free to get it, to choose.
Okay, next. Okay, from Albert Aranyua. Good afternoon and happy Sabbath. Watching from Switch, Ramon Magsaysay. Doctor, nako pangutana about vaccines. Di ba need man ta magpa-vaccine? How about katong mga bata nga dili pwede og one vaccine? Unsa man ilang protection or maunsa man sila?
Okay, yeah. So as what I've told you, the only vaccine na nalantay data is for Pfizer, 12 to 15 years old. And apparently, kids do very well with COVID. We haven't seen like a large group of children, having the COVID and dying. I don't know, God is just so great that even with their immunity not at the max, maybe they're just less exposed to the environment and like to other virulent infections all around. That's why maybe they can mount a good antibody response. But I don't have an answer with that. Basing on on the research data available, only Pfizer has 12 to 15 years old coverage. The rest, wala pa tayo data, only 18 years old. What will happen to them? I hope and pray that we keep them safe. So di nato experimentan unsa mahitabo sa ila whenever they have COVID. That's why our responsibility is to keep ourselves protected and not getting those asymptomatic COVID to prevent us from transmitting it to our children. That's why it's a social responsibility if you think about them.
Okay. Unsa nga vaccine ang safe gamiton, Doc?
Oh, safe. Any vaccine, yes. Any vaccine authorized in your own country, I hope, and FDA approved, authorized that. Any vaccine available? Yes. Grab them, pray about it, and then get it.
Yeah, because there are people who are talking about side effects, no? Like say for example, so is there a specific vaccine nga? If I am 60 years old and above, dili ko pwede nga vaccine. Or if I have this condition at the moment, dili ko pwede nga vaccine. I have to wait for another vaccine. Yeah, if it is not available,
Correct.
So probably this stem from the question nga, unsa ang safe
Yeah.
gamiton.
So, an only contraindication lang, I missed to share this. The only contraindication to vaccination if you have anaphylactic reaction to their components. So if the first vaccine gave you anaphylaxis, nahubag imong baba, di ka ginawa, you were sent to the hospital, na-intubate ka because of that, you cannot get the same vaccine. You can still get a different platform, but to that specific vaccine, no, that's an absolute no. That's an absolute contraindication. But in terms of ages, in terms of comorbidities, most of these vaccines are studied among diabetics, malignancy people, all comorbidities are included. The only limitation is the pregnant and the children. So if you have asthma, dahil kay question about allergies, doc, daghan kog food allergies, makakuha kog vaccine, yes. Na ako'y heart problem, yes. Na ako'y diabetes, yes. Yes, everything is yes. Apart from, are you pregnant? How old are you? 10? Okay, so wala tayong mga data about them. In terms of mga sakit, all of the diseases actually na-cover na nila with the comorbidities with the vaccine trials. So I would say, you'd rather get the vaccine than get the COVID itself. If you have, just think about it. If you have a lot of comorbidities, like diabetes, COPD, cancer, and then you have COVID, good luck to you. You'll really end up in the ICU. So you better get the vaccine than get the COVID.
Okay.
Next question. In your research, Doc, how many % of those who receive mRNA vaccine had cardiomegaly? Is that how it's?
So I actually shared the statistics to you a while ago. It's 100 plus out of 12.5 million. So just get the percentage of that. It's less than even 1%. So it's very, very low. That's why I'm saying benefits outweigh the risk. Very, very low. I haven't even seen one in my own practice. It's just reported.
Okay. I have heard from doctors through the radio that persons who are positive of COVID-19 cannot be vaccinated. But there are people who do not know that they have COVID because they are asymptomatic. Shouldn't there be a swab test swab test first before the vaccination? So the first question is, if you are positive with COVID, can you be vaccinated?
Okay. So currently, if you're positive and you're in the hospital, of course, don't get it. Your system is overwhelmed. But if you're asymptomatic, as what I've told you, and if you're positive for COVID, wait. Just give it to the people who haven't gotten the vaccine and didn't get the virus itself. But if you have enough supply, why not after 10 days? And if you feel like you're okay, because you have the symptoms from COVID, right? You have headaches, you have fevers. You don't want to add up to those symptoms. Pero kung asymptomatic ka and you're positive, and then you have enough vaccine supply, then go get it. There's no contraindication to that. The issue is just like for allocation purposes. Kung natay problem with the supply, paunahan sa itong mga wala nagka-COVID o wala na bakunahan. Maybe wait for some months because you have enough protection. That's what I've said. The best immunity is natural infection. So kung nakay natural infection, daghan kay antibodies, ayaw na pag hinangol sa vaccine, ihatag sa nasa uban. Pero kung nanobra na yung vaccine, go ahead. Why not?
Okay. But let me clarify that, Doc. No? Na question nga. Like, if I already had COVID, because naman siya like a span of time nga, pwede pa ko dili magpa-vaccine. Pero should I really get vaccinated even if I already got or got infected with the virus?
Yeah, so one of the unknowns of COVID and the vaccine itself is the duration and the durability of protection. So based on the preliminary data, 6 months to a year. Some say 3 months to 6 months. So I would say maybe 6 months. Muna imong protection from a natural infection and a COVID and a vaccine protection. So you may get it after 6 months because we have seen the antibodies coming down after 6 months, and we do not actually test antibodies to decide whether you would get the vaccine or not. So I would say wait, but you still can get it. But if you feel not comfortable, I would say just hold off. So it depends on you. It's like you're already vaccinated. Just think about it. Kung nagka-COVID ka, think about I'm already vaccinated. So will I get another vaccine? It's for you to decide, but we still encourage for additional protection. But of course, you have the best immunity already. It's like giving you booster doses already, for COVID. So that's the analogy. You can still get it, but you decide.
Okay.
Okay, next. Does mRNA vaccine reactions like myopericarditis, did I pronounce that right, cause death?
Correct. Yeah, I think I showed this already. The myopericarditis, yes, can cause death if it can give you heart failure at the outset, or if you have fluid around the heart, and that would compromise your heart function, definitely. I saw people not dying from COVID-related myopericarditis. I see people dying from giant cell pericarditis, which is not reported that is caused by the COVID vaccine, but from COVID virus. I mean SARS-CoV. So if they have pericarditis from COVID disease itself, then the mortality is higher. The myopericarditis they see from the vaccine could be vaccine related or not, and the cases are very, very low. But to answer your question, if the patient has myopericarditis, they can die regardless of the cause. But if it's from the virus, they have higher propensity to die from that. It's solely like based on how severe the pericarditis is. Just to explain that it's an actual inflammation of the heart muscle. Myo is heart muscle. So itis is inflammation. So when you say myocarditis, inflammation of the heart muscle, myopericarditis, peri is around. So you have inflammation of the heart muscle and around the heart muscle. So that's more severe than just the muscle itself. So yes, you can die. More likely if you get it from the virus. That's why get the vaccine. Because once you have it from the virus, it's more severe in complication. I've seen one patient with a giant cell myocarditis from the COVID itself, not from the vaccine. And they died. Sorry, he died.
Okay. Doc, thanks a lot for the inputs. My question, why are children below 12 years old seem to be excluded from being vaccinated? Or are they really excluded?
Yeah. So we classify them as vulnerable population. All trials, experiments, we spare kids and pregnant. That's a general rule. Whenever there's medication coming out, usually kids are excluded, and then pregnant women are excluded because they belong to the vulnerable population. And then once we see that the general population actually, safe man pud sila, they can start, recruiting this subpopulation. It's basically from the fact that kung maunsa sila, they are the hope of the sila ang pag-asa ng bayan, mga bata. Imagine mo na annihilate sila tungod. So we have to start first with adults and then go slowly pregnant. That's why I showed you the data. After all these thousands of people participate in the study, then eventually the pregnant, and then eventually the adolescent, and then eventually the children. Yeah, we protect them. They're vulnerable. They're precious.
Okay, next question from Joshua Mendoza. What could be some practical approaches or ways that we can do to encourage anti-vaxxers to get vaccinated aside from health education?
I think pray for them, talk to them in a non-judgmental way. Sometimes masukot ta sa ila, but they also have their own reasons. They do their research as well. Maybe more encouraging, and I think the best one is really health education, and teach them to be open-minded. And ikaw po, mamatik po ka sila. Listen to them. Listen to their concerns because they're valid. Like, they're afraid. I was also afraid at the beginning. I did my research before I even got the vaccine late among all the residents in Einstein Medical Center. Okay, hadlok po ko, di ba? So those fears are valid, and I recognize and I acknowledge them. But the thing is, we just have to be open-minded and listen. So to encourage people, be non-judgmental, talk to them as if they're brothers and friends. They're our friends. They're our brothers and sisters inside the church. Most of them are here. And we just have to let them decide, be more compassionate and considerate, and pray for them, I think, above all.
Okay. This is from Ray Joseph Busico. Hi, Doc. Please explain to us further why people who were completely vaccinated are still getting infected with COVID-19 virus.
Yeah. So that's why we have efficacy rate to tell you. There's no 100% protection. We're not robots after vaccination. The immunity you have is through your blood. You have a blood systemic immunity. If you are too confident about it and then go to the public and did not wear a mask at all, you don't have mucosal immunity. Mucosal immunity is from your nose down to your lining. You have to protect both. Okay, that's why it's very important to have different layers of protection. So that 96% speaks for itself. It's not 100%. So you can have a 4% chance. That 74%, you can have a 26% chance of getting the virus. Okay? So, yeah, that's it. The efficacy rate would answer the question.
Okay, I think we have the last question now. Most of us from Valencia, Bukidnon received Sinovac since Pfizer is not available here. What period of time can we have those mRNA vaccine which can protect us from Delta variant? Thanks, Doc. From Tata de Cruz.
I mean, kanus maabot? Is that a question? Ang Pfizer or...
Period
Sorry,
of time.
can you clarify?
Yeah.
Or like the
No.
duration of time? Protection? I don't get the question. Is it
Or
when will the Pfizer come? Or how long will the protection be?
I think kung
Sinovac
kano sa
before
mabot ang Pfizer,
came?
it's difficult for us to answer that one.
No?
Wala
But
ko
if you have
kabalo.
to paraphrase the question, like say for example, if I already got Sinovac, do I have to wait if I want to get a second vaccine?
Of the same vaccine type.
Yeah, or
Oh,
Or lahi.
lahi. Okay. So maybe I would answer two components there.
because Sinovac is
It's inactivated.
kana inactivated nga virus man. And then Pfizer is
Activated.
mRNA. So how long do I have to wait before getting mRNA?
Oh, so I think ma'am is thinking about switching to mRNA. So actually there's no definite protocol and algorithm for that. Like kanos ka makakuha sa next different platform, because as what I've said, maybe dili man gonna encourage the government. But because siguro supply issues, nahurot na ang Sinovac niya, Pfizer na lang available. So there's no definite period. I would say maybe we would derive the conclusion from different trials. Ng Sinovac could begin after 21 or 28 days. And I would say sa Canada gani karon, they're even expanding the duration between the first and the second dose. As long as you don't get the second dose closer or earlier than the second dose schedule. For example, dapat 3 weeks hindi mo siya kuha on the second dose and you get it in the second week, that second dose could be not as optimal as it should have been given on the third week. Pero kung nakuha ni mo siya after the third week, there's no issue with that. Okay, so even the immune response is better if you get it after the specified period of time. So if nakakuha ka second dose on the second month instead of the first month, that's fine. As long as it's not 1 year gap, if you remember the graph that I showed you, the primary response and then the secondary response, that's just the same, first exposure and second exposure. So maybe you can wait, but I would recommend getting the second vaccine dose if you have it of the same platform than just waiting for the Pfizer. That's what I've said. There's no point of comparison. Just get whatever is available, just so you can have the protection that the second dose, like after the second dose, could afford you.
Okay. A follow-up question to that, Doc. We were mentioning a while ago that we get immunity from katong natural nga being
Infection.
infected, no? So natural infection from the virus. And we were talking about a duration of 6 months. No? Like say for example, you may get after 6 months, pwede siya. If we are talking about this duration from natural infection, do we have, or are we seeing the same, or could we also apply some period of time to the effectivity of the vaccine? Like say for example, ang
Definitely.
vaccine 3 years lang. After that, you get another vaccine. You know, is
Yeah.
it?
So that's actually the answer we are waiting from the phase 4 trials. Kung unsa ka dugayon ang protection that vaccine can afford you. Because technically, the principle of vaccination is we want to simulate a natural infection. That's the goal of it. Gusto nato i-simulate ang mura kag na-infected kunuhay ba sa natural disease, and then you predict how long. Unfortunately, wala pa ta naabot sa period of time nga naabot at 5 years, and then we look back, tanaw nato ang mga tao nga nabakunahan, and we see kung pila sa kabuok sa ilaha ang nagkasakit usab, and we look at maybe their titers. So those are still under study, pero that conclusion is very logical. Like if you say 6 months to a year, maybe the vaccine could afford you that same period of time. So we're just saying maybe karon kay wala pa man tay evidence good like how long. Unlike other vaccines, ginaagid tay specific period of time, like pneumococcal, naagid mga duration of time ba nga naagid tay protection for that specific period of time. And they have gone through phase 4, that's why they're already approved. So we're on the phase 4, ready for approval, and then by then we can have an answer that, oh, we need booster doses, kay 6 months lang na siya. Some people would want to get it, some people wouldn't want to get it, or paingon ng uban, oh, it lasts for 5 years, or 3 or 5 years, for that specific variant, for that specific virus, for that specific spike proteins. So we don't know yet, but we can probably say, yes, 6 months to a year, hopefully, I'm praying. Aron taas-taas na atong duration, we don't need some booster doses. But as what I've said, these are unexplored territory yet and being under study, and then we will soon have an answer, hopefully.
Thank you so much, Doc Pelayo, for the light that you have shared with us this afternoon. We are all blessed by the information that you've received.
My pleasure.
Yes, okay. Well, actually, we are in the closing part of our program, but you might want to greet some people, Doc Gerald. G-boy na lang.
Oh, G-boy na lang. Hello, giving ko sa mga teachers, all the administrative officials there, ako mga classmates diha, and the Advent Philomels, close to my heart. Di na ako kamo may isa-isa, no? Pero I just want to say hi to everyone. Those who are continually praying for us here, we really thank you guys for the support. We really feel at home still. No, maraming na sa Pilipinas, we can still reconnect, and it's nice. I think that's one blessing of the pandemic. We can go anywhere through Zoom. We can speak in different churches. So, regards sa tanan diha, all the students, kamot mo diha. Kay we've been there. It was a very nice time in MBC. I miss those days nga kanta-kanta ta pagkahapon Saturday. I miss those. And the sunsets, and Jubilee Park. Appreciate gini mo pag nana ka sa lahing dapit pa. You will really miss those wonderful moments. And hopefully we can come and visit by 2023. Hopefully, na wala na tayo COVID diha. Kita-kita ta. God bless everyone, and thank you.
Thank you so much, Doc Gerald Pelayo, for joining us. No, sayo kayo sa buntag dito sa US. I was still able to see your guesting sa atong SMM nga Hope Channel. I think that was around 10 o'clock this morning. And siguro you just had to take a few hours or a few minutes of sleep.
Maybe 2 hours.
But really, thank you so much for joining us this afternoon. We really appreciate the time that you have given us. It's enlightening because I have seen nga the vaccination hesitancy has already murag kung ni move na siya to another phase ba. It's on the it's no longer on whether vaccines could help, no, or could give us immunity. It's on the which type of vaccine should we get. No, kaya ang available na to diri is only Sinovac and then wala pa ang Pfizer, no? So because I have seen a lot of Facebook comments nga basta dili Pfizer, dili mi magpabakuna, no? Dili mi magpa-vaccine. So it's on I think people have begun to embrace getting a vaccine, but it's now on what vaccine to take, no? Murag ni advance na pud siya dito. So I hope that our viewers this afternoon, you have been able to glean a lot of things from the discussion that has been made, and also we hope that you could pray about it, no? As really Doc Pelayo is encouraging us to do. He could not, or we could not decide for you. The decision is up to you. But again, it is really our it's a social responsibility, our personal responsibility, not just to other people, but most especially to our loved ones, if we take the vaccine. No? Even the church is encouraging us to take this step. And so, again, we hope that you have been enlightened with our program this afternoon. Some even are suggesting, no, why not invite another individual to share. We'll look into the possibility of that and whether we would need another AY program for that. But once again, we would like to thank you for joining us this afternoon. Ma'am Star, thank you so much for joining us.
Yes, sir. Thank you, sir.
Joining us again.
Okay, so kuan gid karon nakuha no mga issues been clarified. Yeah, with regards to the vaccine.
Okay, and now we will be closing our program with a closing song that will be our Adventist Youth Shine On theme song, and it will be closed by a closing prayer by Brother Seth Manangkil, and we will be back for our closing words before we part this afternoon.
See the light ray, darkness it breaks into the hope of dawn. And one by one, the shadows they run, vanquished by light and sun. Yet every day we need to let His light shine through. Study and love and live and serve together, me and you. Shine through the light, shine through the night, shine in the darkness, shine on through His might. Let the light shine through. Adventist Youth will say to you. Shine through the light, shine through the night, shine in the darkness, shine on through His might. Let the light shine through. Adventist Youth will say to you. Shine on. Adventist Youth shine on.
Shine on.
Adventist Youth shine on. Shine through the light, shine through the night, shine in the darkness, shine on through His light. Let the light shine through. Adventist Youth will say to you. Shine through the light, shine through the night, shine in the darkness, shine on through His light. Let the light shine through. Adventist Youth will say to you. Shine on.
Shine on.
Adventist Youth shine on.
Shine on.
Adventist Youth shine on.
Shine on.
Adventist Youth shine on.
We thank you, Lord, that you have been so good to us, especially, Lord, for giving us another Sabbath. We could indeed enjoy the rest and study your words. We'd like to thank you, Lord, for your productive afternoon in which, through Dr. Gerald Ply, you have shared important information, Lord, in regards to COVID-19 vaccine. We hope and pray, Father, that you will guide us and pour down your wisdom from above as we decide on things, especially on this matter. I would like to ask of you, Lord, that you will continue to be with us May your guidance and protection of the Holy Spirit continue to be with us, Lord, as we journey on through life. Forgive us, Lord, if we have committed sin against Thee. For this I ask in Jesus' name. Amen.
Once again, thank you for joining us this afternoon. Before we part, Ma'am Star, you wish to greet some people?
I'd like to greet my family and everyone who continually support MVC's AY program. Thank you so much for being with us and for joining us this afternoon.
Okay, so once again, I'd like to thank Ma'am Star for joining us again this afternoon. But before we part this afternoon, not a special greetings. We'd like to greet a happy birthday to Ma'am Star. And let's sing, Happy birthday to you. Happy birthday to you. Happy birthday, happy birthday. Happy birthday to you.
Wow, thank you so much.
Happy birthday.
Thank you
Belated
so
happy
much.
birthday, ma'am.
Sir, thank you to the AY family for your surprise. Thank you. Thank you so much.
Okay. Once again, happy birthday, Ma'am Star. Thank you so much for joining us this afternoon, Dagantag viewers this afternoon, because we believe that you also feel that this topic is important and relevant. We will see you all next Sabbath. Until then, Adventist Youth,
Shine on!